Hello, friends. Welcome to Creative Medicine. In this lecture, we will learn about
Then, what are the steps of thyroidectomy? Right. In the thyroidectomy, we put a Kocher's transverse collar incision. This Kocher's transverse collar incision is around 4 to 5 centimeters in length, and it is placed parallel to the neck crease, natural neck crease. It is placed parallel to the natural neck crease, mainly below the cricoid cartilage. So, in the neck, below the cricoid cartilage, we put a 4 to 5 centimeters incision is put, which is called as Kocher's transverse collar incision. After the incision, we will have to incise the subcutaneous, and platysma is incised sharply. The subcutaneous tissues and platysma are incised. Then after incising the subcutaneous tissue and platysma, then we should raise the platysmal flaps. The platysmal flaps are raised superiorly, they are raised up to the level of the thyroid cartilage, whereas inferiorly they are raised up to the level of suprasternal notch. So, once you have put an incision, you will dissect the subcutaneous tissue and the platysma, and after that you will raise the flaps. You will raise the flaps up to, this is the uh, cricoid cartilage, so thyroid cartilage will be above it. So you should raise up to the thyroid cartilage superiorly, and below you will have to raise it up to the suprasternal notch which is present here. Till here you will have to raise the platysmal flaps, so the most of the neck region is visible for the surgery. Then below the platysmal layer you will see the strap muscles. Now these strap muscles should be divided in midline. They should be divided in midline, and you should mobilize them, or along the entire length you will have to divide them, divided in midline along their entire length. Till the flaps you will have to divide them in the midline, and then the thyroid gland is exposed. Once you mobilize the or divide the thyroid strap muscles, like after here you will see that there is strap muscles are seen like this. So now you will see the midline and you will divide them. You won't cut them, you will just divide the strap muscles, and if you divide the strap muscles, the thyroid gland is seen. Now, once you have seen exposed the thyroid gland, first and foremost, we will ligate the veins. That too, first and foremost, a middle thyroid vein is ligated and it is divided. And always, while you are doing the thyroid dissection, you should keep the dissection plane close to the thyroid gland. Okay, and then superior pole vessels are identified. Actually, the superior pole vessels which are present, like thyroid, superior thyroid artery and superior thyroid veins, they are identified. They are skeletonized, and they are also ligated, and then they are divided. All this is done close to the gland. Why? Because superior thyroid gland, these are done close to the gland in order to avoid the injury to the external branch of superior laryngeal nerve. In order to avoid the injury to the external branch of superior laryngeal nerve, we will divide the superior pole vessels, identify and ligate them very close to the gland. Then, recurrent laryngeal nerve is mainly identified at the level of cricoid cartilage. Most of the times, recurrent laryngeal nerve is seen at the level of cricoid cartilage. Then, if you see between the at around 1 centimeter within the inferior laryngeal artery and the recurrent laryngeal nerve, you will see presence of parathyroid are also identified. right? So not just the superior laryngeal nerve, superior pole vessels, but also inferior thyroid vessels. So inferior thyroid vessels are also identified, and they will also skeletonized and ligated and divided. This is also done close to the gland. Why? Because inferior thyroid gland is nearer to the inferior thyroid vessels or artery is nearer to the recurrent laryngeal nerve and parathyroid. In order to minimize the injury to the parathyroid glands and also to prevent the injury to the recurrent laryngeal nerve, we will uh, ligate it close to the gland again. So it is mainly to prevent the injury to the recurrent laryngeal nerve and to prevent the loss of blood supply to the parathyroid glands. Because if there is loss of blood supply, because inferior thyroid vessels also supply the parathyroid glands. So if you are ligating away from the gland, then the pedicle which is supplying the parathyroid may be lost. So in such cases there is increased risk of parathyroid gland infarction may be seen. So in order to prevent that, we ligate it closer to the gland. And recurrent laryngeal nerve injury may also occur more commonly close to the berry aneurysm. So recurrent laryngeal nerve injury most commonly occurs close to the berry ligament. So because it occurs close to the berry ligament, if there is any uh, bleeding occurs close to the berry ligament, if there is any bleeding occurs nearer to the berry ligament, then this bleeding should be controlled. Okay, bleeding in this area should be controlled with gentle pressure, and then after controlling it with gentle pressure, we should identify the vessel. Okay, you should control it with gentle pressure and you should identify the vessel, and then you should ligate the vessel also, so that the recurrent laryngeal nerve is not injured. And one more thing, while you are controlling the bleeding, you should avoid electrocautery usage, because electrocautery can cause, whenever you use electrocautery and if you do electrocautery closer to the recurrent laryngeal nerve, it can cause injury to the recurrent laryngeal nerve, uh, which is not beneficial. Then then so you so here you are dividing the berry ligament. Once you have divided the berry ligament, then the thyroid is separated from the trachea. And once it is separated from the trachea by sharp dissection, we can remove the thyroid and the thyroid gland easily. Now, after you have removed the thyroid gland, parathyroid glands should also be removed. Not should, sorry. Sometimes parathyroid glands might be removed on their own, like accidentally or accidental removal. Sometimes there can occur accidental removal of parathyroid glands can occur sometimes. If there is accidental removal of parathyroid gland occurred, in such cases you will have to take the parathyroid gland and then you should confirm that it is a parathyroid gland by the frozen section. And once you have confirmed that it is parathyroid glands, then you should divide this parathyroid gland into 1 millimeter fragments. Then after division of parathyroid gland into 1 millimeter fragment, you can re-implant the parathyroid gland into the sternocleidomastoid muscle. You can re-implant it. First divide it into 1 to 1 millimeter fragments and then re-implant it into the sternocleidomastoid muscle. And after reimplantation into the sternocleidomastoid muscle, mark the site where you have reimplanted it with the help of a suture or clip, so that in the future if you have to uh, open the neck, you should be sure that the site of parathyroid gland implantation, so that you won't damage the parathyroid glands.
Thank you and thank you for watching.